everyone. My name is Maria Núñez. I'm a fourth-year resident in cardiovascular surgery at the University Hospital Marqués de Valdecilla in Santander, Spain. We wanted to present to you today our endovascular approach for treatment of a patient with the diagnosis of mid-aortic syndrome. The patient was a 14-year-old male that presented a few years prior with a moderate hypertension during a regular visit with his pediatrician. This was an incidental finding. He did not have any limitation of his daily activities, and in fact, he was quite active playing sports regularly. His previous medical history included asthma and atopic dermatitis, and he did have a family history of early onset hypertension on his maternal grandmother's side. On physical examination, he did not show any marfanoid features. His somatic growth was normal for his age. He was found to have blood pressure gradients from upper to lower limb and an abdominal murmur that irradiated to his left hypochondrium. His lower limb pulses were present, although weak. Diagnostic tests showed normal kidney function and inflammatory markers. His ECG was in sinus rhythm with no features of abnormal repolarization or any other anomalies. Transthoracic echo showed mild left ventricular hypertrophy and an ascending aorta with a diameter of 32 millimeters. Renal ultrasound showed normal morphology of his kidneys. He did not have any dilation in the excretory system. We did find a long segment stenosis of the abdominal aorta, so we followed it up with a CT angiogram. I'll show you the images shortly. We did run also a conventional genetic panel to look for known markers of soft tissue disease that was negative. As you can see in the CT angiogram, he does present with a long segment stenosis of the abdominal aorta, is around 3 centimeters below the diaphragm, and is about 11 centimeters long. It does involve the visceral trunks as well as the renal arteries. There's a post-stenotic dilatation of both the celiac trunk and the superior mesenteric artery, as well as the aortoiliac bifurcation. He was found to have an incidental finding of right renal artery saccular aneurysm that you can see over here. The initial treatment approach was to try and do optimal medical therapy for blood pressure control. He did well initially with beta blockers, but in the coming months he presented with somewhat decreased physical activity. He stopped playing sports, and he did refer lower limb paresthesia during long walks. He did need a progressive increase in medication for blood pressure control, and an ambulatory ABPM showed a mean systolic blood pressure above 160. That's why we decided to take a more direct approach to his treatment, and we opted to try and propose an endovascular treatment for this case. We wanted to take into account the fact that he was a teenager with quite a bit of somatic growth still to be had, and also we wanted to keep it as minimally invasive as possible. So in that manner, we knew that we wanted to combine the known effects of progressive dilation with balloon angioplasty with drug-coated balloons. Paclitaxel is an anti-proliferative drug that is well known and well used for treatment of different pathologies like coronary artery disease, as well as renal artery stenosis in some genetic syndromes. And so we decided to take a stepwise approach for this patient and use a drug-coated paclitaxel balloon. And we started treatment in June 2022. During the first session, we did not perform any pre-dilation with any conventional balloons. We went ahead and did balloon angioplasty with the paclitaxel coated balloon. We used initially two 7 by 80 balloons, taking into account that his aorta was had a maximum diameter of 7 millimeters. We did not see any immediate change in the diameters during the angiogram. 1 week post procedure, he was in good shape with the mean blood pressure gradient of 28 millimeters of mercury. Couple of months later, we performed a second session. In this case, we decided to do pre-dilation with conventional balloons of 8 millimeters and followed by two 9 by 80 millimeters impact balloons for angioplasty. As you can see, we decided not to only do this on a stepwise manner, but to increase little by little the size of the balloons that we were using. The mean blood pressure gradient immediately after the second session was 27 millimeters of mercury. We did perform a check angio after a month after the first two sessions, and he was found to have more or less the same diameters as he presented previous to the treatment. He did show quite a bit of somatic growth already when we followed up. He weighed already 70 kilos and his height was 178 centimeters. His mean blood pressure gradient went up to 35 millimeters of mercury. We decided to conclude treatment with a third session where we again perform a pre-dilation with a conventional balloon. In this occasion, we used a 10 millimeter balloon. We had used an 8 millimeter balloon in the second session, and we followed that up with two balloons of 12 by 80 paclitaxel coated balloons. Already during this procedure, in the immediate check angiogram, we saw a 1.5 millimeter increase in diameter within the most critically stenotic areas, especially in the interrenal area. There were some intimal changes on this occasion. We did see a focal area of dissection, but with no acute features and no progression during the immediate checkup. He did have a mean blood pressure gradient of 20 millimeters of mercury. Our next follow-up was already in January 2023. His blood pressure was normal and his blood pressure gradient had decreased down to 10 millimeters of mercury. A month later, in February 2023, he stayed in good shape. His blood pressure was still normal, and his blood pressure gradient from upper to lower limb was 9 millimeters of mercury. We did perform another CT angiogram for checkup, and he was found to have a good increase in diameters, showing an infrarenal diameter of up to 12 millimeters, which is up to 2 millimeters more than on the previous examination. The area of focal dissection was stable with no acute features, and the rest of the exam was stable. There were no changes in the collateral circulation that he already established, and the right renal artery aneurysm was still 10 millimeters. As you can see here, the diameter of the abdominal aorta above the renal arteries is up to almost 12 millimeters of diameter, and also over here, the aortoiliac bifurcation, we got good results with a diameter up to on the right iliac artery, up to 10 millimeters, which is, it was around 8 millimeters on the pre-treatment angiogram. On the left iliac artery, we did have a good increase as well, up to 9 millimeters in diameter. So what we wanted to highlight with this case is what we think is a novel approach in a management of a mid-aortic syndrome patient, trying to stay minimally invasive, as well as taking into account his expected somatic growth. We also believe that it was key to do a stepwise strategy and also taking care to perform pre-dilation with conventional balloons. And we do think that paclitaxel balloons, coated balloons, were a good solution in this patient. Probably the results were related to an inhibition of vascular inflammation and cellular proliferation, similar to that of the known stents used to treat other pathologies. We think that we obtain good results in this patient. He had a sustained improvement in blood pressure control. He did not show any complications associated with treatment, and we avoided open surgery or a more aggressive approach for such a young patient. We do think that diagnosis and prompt intervention are crucial in this pathology, but we also think that we know very little of the pathogenesis of the disease, and especially we don't we need to investigate better options for less invasive treatment and what would be the optimal timing for endovascular or surgical intervention in these patients. We thank you for your time and hope you enjoyed the presentation.